Good evening all, and welcome to tonight's webinar, Medicare Item Numbers and Telehealth Consultations, in relation of course to COVID-19. We are pleased to present this webinar this evening as a partnership between the RACGP, Rural Health West and the WA Primary Health Alliance. We would like to acknowledge the Aboriginal people of the many traditional lands and language groups on which this event is being broadcast, and we pay our respects to elders both past and present. Some housekeeping to start. You'll notice you are all on mute. This is to minimise any background noise. If you are hearing this webinar through your computer speakers and the quality is not too good, you may prefer to switch to your phone. The numbers are listed on the screen and you'll see these numbers too on your webinar dashboard. Please use the chat box if you would like to send through any questions. We have already received some questions and we'll work through these. Please keep your questions to the topic and we'll do our best to cover as much as we can. The webinar topics this evening will include the following: an update on the temporary MBS item numbers presented by Sarah Renwick, Senior Policy Advisor from WAFA. This will be followed by Dr. Olga Ward, Rural Health West Medical Advisor, and Dr. Damien Zilm, a GP with extensive rural and emergency telehealth service experience, both chatting about the telehealth consultation from a rural perspective. The webinar will finish with an overview of the Health Direct video platform. This is a Commonwealth-funded platform and free of charge to all GPs. This will be presented by Joe Hughes, the Video Call Service Manager from Health Direct. We are recording the webinar this evening and we will upload the recording to all of the partnering organisations' website. We will also email it out to all participants, including any other relevant resources. We'll now hand over the reins to Sarah from WAFA.
Thank you for that, Beth. As mentioned, my name is Sarah Renwick and I am the Senior Policy Advisor at the WA Primary Health Alliance. Just for a little bit of background, I'm sure you're all aware, but WA Primary Health Alliance is the operator of WA's 3 primary health networks, Perth North, Perth South and Country WA, which is all part of the Australian Government's National PHN program. A key part of our role is to provide support to general practices across WA. We do this through our team of primary health liaisons, our practice assist website and help desk, which is in partnership with Rural Health West, and our comprehensive primary care program. To date, we have been supporting general practices with the COVID-19 response through the distribution of masks and daily updates in partnership with the WA Department of Health, AMA WA, Rural Health West and RACGP WA. Next slide. So a reminder before we begin, this presentation is intended as a general guide only. Please make sure that any services you bill meet the requirements set out in the legislation. I think I'll also flag, as I'm sure you're all aware, this is a really rapidly changing space. The Australian Government has advised that there will be further changes to come with the MBS items. So what is current today will probably not be current next week. The department is currently consulting with the AMA, RACGP, ACRM and the Rural Doctors Association of Australia to co-design what they are referring to as stage 4 of changes to the MBS telehealth items. Yesterday, the Minister for Health, Greg Hunt, announced that these changes were expected to be in place by the 30th of March 2020, which is next Monday. Next slide. Okay, so as most of you are aware, on the 13th of March, the Australian Government made additional MBS items available in response to the COVID-19 pandemic. These items are to support telehealth and phone consultations for health professionals at risk of COVID and for patients at risk of COVID-19. And I'll define those definitions in a moment. For items in subgroup 1 and 2, the patient must have had at least one face-to-face attendance in the last 12 months with the GP or medical practitioner who provides the service, or the practice where the GP or medical practitioner is employed. Now, this has slightly changed in the last few days, so now this only applies to patients that meet Part C of the definition, which I'll explain in a minute. The service must meet the definition of a telehealth attendance or a phone attendance as set out in the legislation, and the service must be bulk billed. A reminder as well that these items are only temporary and available until the 30th of September. Next slide. So a health professional at risk of COVID-19 is defined as a health professional who's been diagnosed with COVID-19 but not a patient of a hospital, has been required to isolate, or is considered to be more susceptible to COVID-19. So this has just been expanded in the last few days. So now this can be a health professional at risk because they're 70 years or older, 50 years or older for Aboriginal and Torres Strait Islander people, pregnant, a parent of a child under 12 months, or a person under treatment for chronic health conditions or who are immunocompromised. Next slide. So the definition for a patient at risk of COVID-19 now matches that of a health professional at risk of COVID-19. As I mentioned previously, a recent change has been that for patients that are only at risk of COVID-19 because they're more susceptible, so that is they're 70 years or older, 50 years or older for Aboriginal and Torres Strait Islander people, pregnant, a parent of a child under 12 months, or under treatment for chronic health conditions or immune compromised, they need to have had a face-to-face appointment with the GP in the past 12 months or the practice that the GP is employed at. Next slide. Okay, on to the items themselves. So subgroup 1 includes 9 telehealth items for GPs and medical practitioners. Items are time-based and the appointment must include one of the following. So taking a short patient history, arranging any necessary investigations, implementing a management plan, or providing appropriate preventative health care. These items attract a rebate of between $44.90 and $128.05, depending on the provider and the length of appointment. Next slide. So the items in subgroup 2 reflect those of subgroup 1. The difference is that these ones are for phone attendance. There is the same criteria that they must include one of the following, taking a short patient history, etc. And they attract the same rebate as the items in subgroup 1. Next slide. Subgroup 1 and 2 also include 6 brief telehealth and phone attendance items. So for GPs, these are for an obvious problem characterised by the straightforward nature of the task that requires a short patient history and, if required, limited management. For medical practitioners and medical practitioners in eligible areas, these attendants must be not more than 5 minutes. These items attract a rebate of between $12.90 and $20.55, depending on the provider. Next slide. So there are also 8 new telehealth items and phone items for nurse practitioners, and I thought this might be relevant for any nurse practitioners who might be on the webinar tonight, or if you have nurse practitioners working at your practice. So these items are available again for health professionals at risk of COVID-19, meaning the nurse practitioner, or for patients at risk of COVID-19, so it's the same definition. There are 2 items for that are brief appointments, so it's the same definition as a GP, so an obvious problem characterised by the straightforward nature of the task that requires a short patient history and, if required, limited management. The remaining items for nurse practitioners are time-based and must include one of the following: taking a short history, arranging necessary investigations, implementing a management plan, or providing preventative health care. These items for nurse practitioners attract a rebate of between $9.75 and $59.50, depending on the length of the appointment. Next slide. So I've also included a section in here on the focused psychological strategies items. Focused psychological strategies are defined as meaning any of the following healthcare management strategies which have been derived from evidence-based psychological therapies. So this includes things like psychoeducation, cognitive behavioural therapy, relaxation strategies, skills training, and interpersonal therapy. Next slide. So there are 4 new items for telehealth and 4 items for phone consultations for the purpose of focused psychological strategies provided by GPs and medical practitioners. These items are for the provision of psychological strategies for assessed mental disorders, as long as the practitioner is credentialed by Medicare to do this. These items attract a rebate of between $88.70 and $158.60, depending on the provider and the length of appointment. Next slide. There are also a number of new telehealth and phone items available to eligible clinical psychologists, occupational therapists, and social workers. And I guess this is relevant when you're thinking about where you can refer patients if you know they're going to need to access a telehealth appointment. These items are for the provision of psychological strategies for assessed mental disorders by allied health professionals, again, as long as the practitioner is credentialed by Medicare to do this. These items are available for health professionals at risk of COVID-19, again meaning the allied health professional, so the psychologist or occupational therapist, or for patients at risk of COVID-19. Again, these items are time-based. Patients need to be referred by a medical practitioner as part of a GP mental health treatment plan or a specialist in psychiatry or paediatrics. These items attract a rebate of between $63.25 and $148.80, depending on the provider and the length of the appointment.
So Sarah, can I just, sorry, it's
Yes.
Olga, can I just jump in there?
Of course.
So if the patient already has a mental health treatment plan and
Yes.
is already undergoing some psychological treatment,
Yep.
it can be continued by telehealth.
Correct.
But if they haven't already got a referral,
Yes.
they will first need to have a referral provided.
They will, yes. And two things to note on that. The GP mental health treatment plan can't be done. There's not a new telehealth item for that. Hopefully next week
Till next
we
week.
can get that. And the other point I'll make is that this is not additional sessions. So on the mental health treatment plan, patients get those 10 sessions. This doesn't give them any extra. So there's no additional amount available. So they still need to be within those 10 sessions with a psychologist.
And just going back to your previous comment, which was for eligible doctors doing mental health reviews.
Yes.
You're talking about people who have done additional training in mental health.
Yes.
You're not talking about just a normal GP billing what would be in a face-to-face at 2713.
Correct. You need to be you need to have done the training that's set out by Medicare in order to provide those focused psychological strategies. Yeah.
Thanks.
And next slide, I'm actually at the end, so that was very convenient timing. I've just got on here some key resources. So because this is changing all the time, the legislation is really the key place to go, as well as MBS Online. WAFA's Practice Assist website has some resources, and we are sending out daily updates to practices who are registered. So if you're not registered with us, please make sure you visit the website and sign up to the updates. RACGP and ACRM have some fantastic resources that are very short, concise, and to the point that are really useful. And the other place that has a lot of useful information are the medical indemnity provider websites. They've got some interesting FAQs around confidentiality and privacy, which I'm sure we will talk about a bit tonight.
Sure.
All right, we've got some questions.
We do indeed have some questions. So somebody has asked if these items can be bulk billed.
They must be bulk billed.
They must be bulk billed.
They absolutely must be bulk billed. That is a key part of the criteria.
Mm-hmm. Somebody has also asked, what's the difference between a medical practitioner and a GP?
There is a different definition. Hang on, I'm just looking through my notes to see if I copied and pasted it. I didn't, but they are it's defined in the legislation, so I can certainly get that definition up and I can read that out perhaps later in the session.
Thanks. But a GP is defined as a GP with specialist postgraduate general practice training.
Yeah.
Somebody who is billing the rural,
the VR status. It's vocationally registered.
Or somebody who is a registered GP registrar with either college.
Yeah.
Somebody has asked you to provide the telephone numbers again. We will put those, can we put those on the screen? They will be in the information pack that you will get on your email.
So someone's asked about the criteria from sorry, I'm getting my notes up, from the Australian Health Protection Principle Committee. At the moment, the current advice, and this is subject to change, is if the person has returned to Australia from overseas or been in close contact with a confirmed case of coronavirus. That's the current advice.
Mm-hmm. And somebody has asked a very relevant question, which is if you are self-isolating because you are the doctor, do you require a home provider number, or can you do this via your practice provider number?
Ooh, that is a good question. I assume you can do it by your practice number, but that's a good question that I think we should probably take away and get a definite answer on.
Yeah. Well, I mean, it would be logical, but the MBS is not
you never know.
Logical.
You never know. Yeah. All right. So I will hand back over to Dr. Olga Ward and Dr. Damien Zilm. Thank you all very much.
Good evening all.
And good evening. Eventually we'll appear on a camera with any luck, but thank you very much for joining us, and thanks for joining us, Damien. We're two old country GPs, so you'll probably get some of our perspective on how we're coping. And Damien, how is your practice coping with new telehealth item numbers and rapidly changing requirements?
Certainly a learning process. We've been quite fortunate in terms of the lockdown at the moment with limited in and out from Megathera. Certainly across the state through emergency telehealth, there's been a lot of consults coming through, people asking questions about testing and then following the guidelines for testing.
Yeah. Now, my patients are also, they're concerned about testing, they're concerned about isolating, they're concerned about accessing telehealth. How have you set up telehealth in your practice?
So the way that we're looking at doing things is, I suppose, first of all, is the process of patients getting appointments, which should be coming through the front desk. There should be a discussion about the appropriateness of that, a booking made so that the GP can then call them back. There may need to be some screening done by the health nurse. Certainly, I think setting patient expectations about what can be delivered, what can't be delivered, and certain things that might be needed to be provided, such as a photo if there's a rash or something else like that. Certainly making certain that photo is in focus, and then obviously setting up for the consult itself.
Yeah,
Is that what you're doing?
I must admit I'm doing telephone rather than video, and that's because of rather stuttering internet, and particularly I think a lot of bandwidth is being used up by people who are either working from home or more likely their teenagers are downloading Netflix from home. So I find that things drop out quite frequently, but the telephone line seems so far to be fairly reliable. And I'm finding that I can do an enormous amount just with a phone and a still picture if I need to. And occasionally a family member or somebody else who happens to be there if I need something like a temperature or whatever checked.
I think that the experience across country are GPs are using a lot of phone communication. There'll be those that are using FaceTime. There are those that will be using Skype. And there'll be those that will be using other programs such as the Health Direct, which is coming out. I think the key things here are bandwidth, safe provision, not having something drop out. It's always a little bit of a challenging situation doing a VC or a telephone consult, I find. I find that there are increased risks in terms of doing it, and providing that consult safely is probably the crucial and the key factor. And there will be patients where you cannot safely provide telehealth, and they will need to come in face-to-face or be asked to present either to see you or to the hospital.
Yeah. Now, if you've done, say, a telephone consultation with a patient earlier in the day, and you decide that absolutely you need to have a look at this, and you get them in, can Medicare, in your understanding, be billed for second essential consultation same day?
Yes, I understand that is the case. I think it's interesting though, at the moment, given the limitations regarding who would be seen, I think chances are that person would be seen by one of your colleagues.
Yes, it's a really evolving space, isn't it? A lot of patients are having mental health issues, and I understand that on Monday the scope of the item numbers is going to be expanded somewhat. I would think that mental health items in particular are useful to be able to do on telehealth.
Absolutely agree.
Somebody has asked about billing patients. Now, I think at the moment all patients who meet the criteria must be bulk billed. I'm guessing that if you provided telehealth consultation to the patients outside that, it would be an all private with no item number until Monday.
I would expect that to be the case, and I know there's a number of private providers that provide services via telehealth outside of the MBS. I'm guessing that would always be an option.
Yeah, and is it your understanding that with the definition of these item numbers that they can't be private billed, or there can be no gap?
It's been very directive at the moment that they must be bulk billed.
Yep. Yeah. I agree. Somebody has asked, would a GP who's covered a shift in a COVID clinic, and I'm guessing this will be some of our urban and regional counterparts, then be permitted to telehealth from home in order to not expose co-workers?
I'd be looking at that very directly at the criteria. I don't think that meets current criteria.
No. And again, it's going to change on Monday the 30th. So maybe that GP who asked that question will be running something different on Monday.
Can I just interrupt? I'm just thinking, I read a couple of the questions there, and I think maybe the audience might want to know something about documentation and about how they then do that with the patient. Can I?
Yes,
well,
absolutely.
I don't know what your thoughts are to
because
that.
I'm finding that quite difficult, particularly if I have to, being in a vulnerable category myself. I've had to do some telehealth from home. I'm just finding that I type my notes on the computer and email them as a non-rewritable PDF direct to my practice, and they get dropped in the patient's notes. But I'm guessing I'm going to be doing some telehealth from the practice tomorrow, and I'm going to be typing directly in the notes. How about you?
And I think there are those that will be able to have access via cloud-based remote access to their server. So they'll be able to put notes directly into the patient files. I think there'll be some practices which need to make a decision and discussion with their IT providers about what they can actually, what access they can have remotely to their server. There have been questions about provision of scripts, and I think the easiest way of doing that is to have it printed off, needs to be posted off to the pharmacy or to the patient, contact made to the pharmacy, and also faxed through so the pharmacy has that as well. I think the same applies then for pathology and radiology, and I think this is the absolutely crucial thing there about having remote access to the practice, because somebody has to be looking at any results that you've then ordered as well.
Yes, and that's going to be mighty difficult unless, I guess, you come in full PPE to the practice after hours and have a look at your results. Logistics are a bit of a nightmare, and they're a bit more of a nightmare, although I think this might actually improve some of the access for some of our more remote rural patients.
Can I speak a bit about that?
Yeah.
Because certainly in some of the areas, I know that a lot of patients will struggle with being able to access VC or any of the app-based programs that some of the practices might choose. Certainly, I think phone is going to be the most reliable and the easiest way of going. I think as you start going to VC, which provides a better service as long as you've got good connectivity and you can communicate well with the patient, actually see how they look and how they present, that may be a little bit more difficult. I think as well that cultural issues, there'll be language barriers, some of our older patients not being very IT savvy, hard of hearing, there'll be some language issues as well.
Yeah,
and I think some of those is going to be
telephone interpreter service quite frequently, but I suspect that we may have to use on-site family members at times for clarification.
I know certainly that I've done that, and I've found that actually quite helpful. And sometimes just to clarify with another family member, from a consent point of view, I've always looked at it from the patient's given consent for that family member to be there. I've also found some of the simple examinations that you might be able to do. I mean, you can quite easily see if somebody's tummy is absolutely soft, but I think if you've got any greater concerns, that person needs to be seen. It's all about providing and practicing safely on telehealth.
Yeah, and so what happens when you kind of look at the triage category of the patient, or you decide they do actually need to come in, and what happens with, say, your patients that are coming into the practice because of their nodular melanoma, or their somebody's asked about cervical screening, although I think we could probably delay that for a little while. It's all a bit of a fine balancing act, really.
Yeah,
I think
certainly there should be a discussion, I think, happening at the front desk with those patients who are at higher risk being identified, and move to a safe part of the surgery or an isolated part of the surgery, whether it be the nurse's room, depending on what's happening with workflows and activity. But I think it's a conversation for every practice to have about how they're going to manage that.
Yes, and it's going to be so different depending on where you are, what resources you are, and how much ability do you have for isolating.
I mean, I'm aware of some consults actually happening in a car to keep the patient safe where that might be appropriate, and I think that's actually quite a safe thing to do.
Yep.
I think my feedback so far is there's many patients that are happy with that because they know that they're isolated themselves in the car. They're not coming to a practice. They feel safer that way.
Yeah, and of course with the influenza season almost upon us, and the vaccination season almost upon us, I'm thinking that we're going to be vaccinating an enormous number of patients in their car.
Yeah. Which then comes to its own risks about observing and things in the car as well. But I think that's going to be a matter of each practice and each practitioner being happy with the practice that they're performing.
Yeah. Somebody has said, I note they've required 3 face-to-face consultations in the last 12 months. I think that's going to change on Monday.
I think that, was that in the advice there, it was reduced to 1 currently?
For these items, it's 1. For the existing telehealth items for rural and remote areas, it is the 3 in MMM 6 and 7.
Oh, so the original
different items,
So we're not sure if the microphone picked that up. But so if you're using the rural GP telehealth item numbers, currently the recommendation is 3 face-to-face consultations in the last 12 months. If you're using the COVID-19 criteria, then it's just literally what you've seen on your screen.
Yeah.
At-risk patient or at-risk practitioner. I have to say, it's very helpful when doing telehealth for patients to actually have a good understanding of who the patient is, where they live, and what's going on. So I suspect that most patients are going to do better with their usual practitioner in these circumstances, regardless.
Absolutely agree. There were a couple other questions which were raised. One was about concerns about prescribing of benzos and of Schedule 8s.
Yes, and also just even signing the prescriptions if you're not actually in the practice because you're at home in isolation. Do you get a colleague to write the prescriptions, or do you just sign manual ones? Like, I'd be happy to kind of sign manual ones at home and scan an email to the pharmacy and then batch them and post them.
That's certainly what I've done when I'm at home. I mean, I've even used, if I haven't got a script pad on me, I've used computer paper and actually written things on both sides with all the information on there, and that has been accepted. And I think in the circumstances here, that wouldn't be a problem to do. Not ideal, but it's certainly a good workaround.
Yeah. And consent, Damien, I'm just going back. Sorry, we are jumping backwards and forwards a little bit, but if you're trying to, say, assess something from a photograph, in terms of the security of that medical information which is bouncing around, how do you go about receiving a photograph and putting it safely in their notes?
So I suppose there's a few issues here with this, and certainly there is quite a bit of advice online from our MDOs regarding storage of clinical photographs. There's advice to the patient about what they're sending. So there shouldn't be identifying features of the patient, certainly anything which might be considered to be used for children, which might be illicit. Be very, very careful. That should not be sent. Anything which is sent should be deleted. It's fine to save it in the patient notes, but should be deleted from all devices otherwise. And under accreditation guidelines with RACGP, there should be a policy in place of the practice to make certain that those clinical images are being managed correctly.
Yep.
I'm also guessing as well that if the patient has actually sent through those, that can be implied consent. They have sent that through or giving their consent for that to be seen by the practitioner.
Yeah, and I'm guessing it won't hurt to document that.
No. I think coming back here, as I was saying before, their documentation is key. And I think although this is a different space for a lot of people, if it's not documented, it didn't occur. And I don't think there can be any cutting corners or anything for this. It is, my opinion is this is a high risk area. Things can be missed. And so documenting very clearly in terms of those areas that you think are a higher risk for patient management needs to be clearly documented what you've advised the patient to do.
Yeah. Now, Damien, you do a lot of ETS and inpatient telehealth. Have you got any tips for examining people via telehealth?
We're fortunate to have nurses at our sites which make that easier. But in terms of being able to examine, you can certainly, over telephone, it's going to be quite difficult. I find that in my consults, probably 80% of what I do is history, 15% is examination, and probably 5% then is special tests. And I see that no different from a telehealth point of view. So examining patients for those things which are relevant, certainly look, feel, move. You can get the person to move around if you're on some form of audio visual. In terms of examining somebody for pain, feeling their tummy and actually having something, giving them quite specific directions in terms of what they should be doing is something I find works very well. They can feel their tummy. You can see how far they're pushing. You see if they're wincing on their face. You can see how they're moving. And again, be risk adverse. If you think there's something there that you can't exclude with safety, that person should be seen. I mean, it does come down, I think, to clinical acumen, but I think you can quite easily see if that person is safe or if you actually need to come in for a physical examination.
I'm finding I can do a fair bit just with patients who are fairly well known to me, just by asking them, for instance, how far can you bend your elbow?
Yeah.
What can you pick up with your hand? You know, how is your grip? Trying to diagnose a Bell's palsy over a telephone was interesting, but we managed to differentiate that from a stroke and get the patient the appropriate treatment. You know, I think it can be done, but boy, you have to ask a lot of questions and you have to be extraordinarily specific, I think, in your instructions to the patient, because they often really don't know what they're doing.
I find communication is absolutely key, being very specific in your questions, being very clear, and making certain that the person has actually heard and understood you.
Yep. Sorry, I'm just looking through the questions that people have sent in. People did ask about care plans and chronic disease items, and could these be done via telehealth? I'm guessing by Monday they quite possibly could be, and people's chronic diseases are still going to require management. And perhaps doing a care plan via telehealth isn't as unnecessary as it seems at the moment if you're trying to get an overall plan for how are we going to manage this with limited interpersonal contact over the next pretty much 6 months?
I'd agree with that. I think the key things with that is making certain that we're meeting the Medicare requirements within that. And myself, I would always be doing that on the computer program. So remote access, if I'm not in there, providing it from the rooms.
Yeah, I think it would be very difficult to try and do that one from home.
I think it'd probably be inappropriate.
I'm looking forward to seeing how tele-allied health works out. There's certainly quite a lot of availability, although not usually funded availability, for things like physiotherapists and exercise physiologists just reviewing how people are doing their post-knee replacement exercises when they've gone back to a remote area. And I think that's going to be something that perhaps would be good. And of course, we're going to be trying to get them out of the infectious cesspools that are hospitals and back to their nice isolated farm as quickly as possible. Somebody has asked if you need to advise your Medical Defence Association whether you're doing telehealth consults. I'm guessing that the MDOs would know that most GPs will be doing telehealth in these rather exceptional circumstances.
When I started, I did notify my MDO. I don't think it was actually required for me to do that as long as I was providing within consistent guidelines. But yeah, I think it's pretty fair to say that they'll know that we're going to be doing it.
Yeah.
And it needs to be covered.
And you're talking much more about ETS when you first started, which for those of you who are in the city is the emergency telehealth platform that we use for doctors in a regional centre to be able to assist doctors and teams on the ground in an emergency in a rural or remote centre.
Yeah. There was a question as well people had about the suitability of mental health over a telehealth platform. Certainly ETS mental health exists. That is over VC to our emergency departments, and that runs very effectively. That significantly reduced the transfer rate out. And I know that WAF has been through Ports, has been providing psychology, telephone service to patients. Initially there was some perceived pushback from that, but it's been well received by patients and well uptake. It's also a good uptake without the concerns that were there, and patients are just thankful for being able to have service provided in their home or in their home community.
And they're extraordinarily grateful to have somebody that they know.
Yeah.
So that might be something that really flies. Damien, how are you managing your nursing home patients by telehealth, given that they're often hard of hearing and frequently demented and unsteady?
I'll probably have to defer to your experience on that. In Meeka, we've got aged care residents within the aged care facility. So that's not something I'm doing, but I could certainly provide some thoughts and advice through that.
Yeah, well, certainly in a community aged care facility, we're doing okay. One of the things that I did notice that maybe the doctors and other health professionals need to feed back to the nursing homes is please don't use the same iPad for all of the residents to use without thoroughly cleaning it in between patients. And I'm finding that the telephone is fine for my patients who can more or less hear and more or less understand. But again, that's going to be very individual, and hopefully the usual doctor will be able to do that.
I think the great advantage of nursing home is that there's going to invariably be a nurse that you'll be able to do around with who can tell you how they've been examined and anything else which might be relevant. So I think that actually makes it much easier and certainly reduces the risk of we as practitioners needing to visit the nursing homes and then potentially transmit COVID inside.
Yeah. And just finally, there was somebody asked about after hours telehealth item numbers and doctors with provider number restrictions, so DPA restrictions on their provider number. And I'm not entirely sure what's happening. I'm guessing that they will be coming under the other medical practitioner, as in non-specialist GP or non-GP specialist item numbers for telehealth.
My thoughts certainly in terms of after hours, I think there's only one number that applies to all at the moment unless something else is announced. And I think that...
And it'll probably change on Monday.
And I think if somebody has a geographically restricted provider number, I think they would need to obtain information specific. And I imagine that the department's actually communicating specifically with them about the implications for their provider number. And certainly my advice would be to obtain information from the department specifically on what one can do if they don't have VR status unrestricted.
Yeah, and hopefully Ask MBS will be briefed to put out a consistent message. That's something that we have unfortunately no control over. Do we have any other questions on here?
Is it legal to sign another doctor's scripts? No.
No.
And the comment I was going to make before about benzos and Schedule 8s, if you haven't prescribed, sorry, it should be prescribed by the regular doctor. That would be my strong advice, or have a discussion with the regular doctor, and otherwise don't be prescribing it. The other thing that I think is absolutely key is the just in case antibiotics and other things. I certainly would not be prescribing. There's a lot of concern about runs on antibiotics and other medications which are happening at the moment. You can be guaranteed somebody gets something, they're going to take a medication which is not appropriate. We've now got access to telehealth, which makes it easy or easier, and there's certainly options there. And if somebody actually truly needs an antibiotic, meets criteria, there's means and ways. I mean, the last resort is they present to an emergency department. And certainly in country, that would mean that they would be seen by either a doctor on the ground there or by ETS.
Yeah.
Or by their own GP.
By their own GP at whatever location.
Who may actually be able to just give phone advice without having to come in to see them as well.
I think, you know, just in case antibiotics are suitable, certainly pretty much the only situation I give those in is patients who've had a renal transplant or a bone marrow transplant.
Yep.
But they know that they've got those just in case antibiotics sitting at home, also because the pharmacy is 50 kilometres away. But they will still phone me for a phone consult, which up till now has not been reimbursed by Medicare at all, before they start taking them.
And I think that's absolutely essential, especially with the data coming out about likely inappropriate prescribing of antibiotics.
Yeah. What else do we have? Proposed rural, still in existence. The proposed rural-only item numbers for telehealth, yes, they are still in existence, and the requirements for those are exactly the same as the requirements for those were previously.
I might just make a couple of questions. Certainly in terms of data transmission, there is concern at the moment about the use of home consumption of data with people working from the home instead of the workplace. I think that's going to destabilise some of our audiovisual platforms.
Yeah.
I think we need to be very mindful of that. I think we also need to be mindful that the satellite broadband, or NBN, is somewhat temperamental. I don't know how successful that would be in providing a telehealth consult that's not phone.
Yeah, and you know, both of our experiences that Skype drops out, Zoom drops out, many of those things drop out. We're looking at this Health Direct platform very shortly, and hopefully they'll be able to answer some questions. But at the moment, you can use whatever platform works, being mindful of the privacy implications of using a relatively non-secure platform.
There are a couple of questions about recording of the consult through, I think, Zoom or a couple of other ones there. My advice is don't. It shouldn't be retained. It's of no benefit to the patient or to anybody else, and potentially compromises the patient confidentiality.
Yeah.
And I think as well, phone's always going to be a reliable backup. And if the AV doesn't work or the person can't download a program or something else like that, default to phone.
Yeah.
And just make certain you're managing things safely and then documenting as well.
And then when you're following the patient up, you've still got the same responsibilities to follow up anything that requires follow-up.
Yeah.
If you've done a teleconsultation, as you would have if you'd seen the patient in the practice. So we need to somehow arrange for anything important that requires following up to be followed up, and whether that's emailing or calling your practice, or being able to remote into your practice notes and actually ping a recall or a follow-up on the practice software, you need to be able to do that somehow. And if all else fails, then pens and paper still work quite well.
Yeah. Although I think I'd be very careful. Except there's one source point of truth there with everything documented properly. I can see notes going missing.
Yeah. And just finally, before we head off to talk about Health Direct, I just wanted to let people know that all WACS sites are doing the swabbing.
So all WACS sites, if somebody's got COVID, if you suspect
and if you've done a teleconsult and you think, gosh, this patient is not just at risk, but they've got symptoms and they need testing and they're rural.
Yeah. So a WACS site, that'll be seen by either ETS or by the local clinical governance pathways that might be in existence in some of the very, very small sites. Otherwise, across Metro, it's the COVID clinics or the tertiary EDs.
Yeah. And if somebody presents to their local WACS site, then their WACS site will be able to have a protocol that they will be able to follow for testing that patient.
Which is up to date, maybe twice a day up to date.
Yeah. Fantastic. Thanks so much for joining us,
Thank
Damien, for this slightly all over the place, but nonetheless, hopefully informative discussion. We're going to hand over now to Joe Hughes. Joe is from Health Direct, which is a video call service platform that has been Commonwealth funded and is free to access.
Oh, thank you for having me. Yes, I'm Jo Hughes, the Service Manager for Health Direct Video Call. Video Call, as mentioned, is a platform that's been developed by Health Direct over the last 6 years to enable clinicians to offer telehealth to their patients as simply as possible. So without further ado, I will be showing you some of the basics of the platform, but just to say it is free to access. It's all government funded through the Commonwealth and state governments, and we're offering access to GPs and other providers via PHNs. So the platform itself has been specifically designed for healthcare and has been built in line with security and privacy standards, the government standards for privacy and security. So I'm just going to show you a quick view of the platform and some of the features. So running through how, as a GP or other health service provider, you would basically meet your patients online to do a telehealth appointment. So I'm showing you at the moment, I'm just going to check. Yep, so I'm showing you at the moment a web page that we've just set up for our demonstration clinic. So we call it Acme Health Clinic, and this is to show you how a patient would arrive into your video call clinic. So you basically be sending a link to a patient and they would have the same link every time to your practice, a bit like sending them an address. It's the same time, it's the front door to the practice. So they click on the link, click on the button on the web page. It doesn't have to have a button on a web page. You can send just a URL, but we recommend a web page. It's just a nice feel for a patient. They start a video call, and while that's loading, just to say we don't have an appointment or booking system as part of the platform. We recommend you just use your normal appointment booking systems and just tag it in the system as a telehealth appointment. So the patient will get this screen and they will see themselves. So there's me in that little circle. So you can see that your camera is working, and they will enter their name. So I'll just enter my name here. And put in a phone number. And then accept terms of use and continue in. Oh, it's not liking my phone number. Continue into what is essentially a waiting area. So there is music that patients can listen to while they're waiting, and you can also enable messages to be presented to the patient while they wait. So I'm just going to show you now. I'm just going to actually leave the queue here because I don't want to take up too much bandwidth on this call. And I'm just going to show you now. So now, as a clinician or a health provider or a receptionist or a practice manager within a health service, this is how you would log into the system if you were given an account. So you can, I won't go into how accounts are set up, but that's very straightforward. Once you have your account set up, you basically enter your email address and your password that you've set, and then you log in. And then you can see all your clinics. So I've actually logged in earlier to a clinic that I have access to, and I'm just going to come in on my mobile phone as a patient. So this platform is basically been designed to be used on everyday devices such as iPhones, iPads, Android tablets, Android phones, laptops, that as long as you've got Google Chrome on your laptop, or you've got Safari on your iPad, or Google Chrome on a tab on an Android, you can access video call either as a patient or as a provider. So I've come in, my patient is on, Chris Smith is on their iPhone, and they're waiting to be seen. So hopefully you can see here, this is the waiting area. So you could have many patients within the waiting area waiting to be seen by you or your colleagues, and your colleagues, you and your colleagues would have access to this clinic. So what you can do when you're ready to join the patient is click the blue button. But a couple of little features are that you could send a message to the patient to say maybe you're running 10 minutes late or something, or you can tell them to get something ready while they're waiting before you join the call. So I'll just show you some features on the right hand side as well. So you can actually set up alerts for your mobile phone to be alerted when someone comes into the waiting area within your clinic. So you can get an SMS sent to you automatically to remind you. Perhaps even you may have gone off on a break, or if you get a break, or you may have just, you may not realize you've got a telehealth appointment as opposed to an in-person appointment. You can also have email alerts and little pop-ups on your desktop. Just to note this here, down here, you can see a little green copy button. So that's the link that you would send your patient to come into the waiting area. So if you don't have a button on a web page, this is the link, and it's the same link every time. So that's why you don't have to worry about different links for different appointments. It's just they always come through your front door, which is yeah, it's just a consistent link. So I'm just going to show you as well. So this is a sort of third aspect of our service at Health Direct. So we've built a resource centre, and we have obviously a team of people that support people and organisations coming on board with video call. So this is the resource centre. It contains it's like lots of user guides, resources that you can use, so letters that you can send to patients that show them how to get into the call, and lots of there's some technical requirements that are useful, just sort of the basics for what sort of information or what sort of technology you need to use video call. So I won't go into too much detail there around that. But yeah, so we're working with PHNs all around Australia to set up arrangements to enable GPs to access the platform. And we already have lots of practices that have come on board this week. Obviously, we've had a huge spike in interest and a huge spike in calls that have been going on the platform, probably at least 10, 20 times what we would have normally had. So we've been making sure that we can withstand the extra demand. And so perhaps I'll finish there, but it obviously keen to hear any questions that you may have around this or other video other video platforms. Okay, now I can't hear. Oh yes.
Joe, just a few questions. How do patients go if they've got a prepaid phone?
So if they've got, you mean if they've got fairly low data available to them?
Yeah.
Or if they're paying by the minute, sort of having to put credit on their phone.
Yeah. So if you have a 10-minute consultation on your phone, it would be about the same as watching a 10-minute video on Netflix or on YouTube or something. So it doesn't chew up a lot of bandwidth, but yeah, obviously it would slightly impact perhaps your daily or monthly allowance if you only had a very small data package. I think these days, you know, even within the last year, mobile providers are being more generous with their package of data, but I do, yes, it could be a problem. And what we have been seeing is people accessing community services to access computers or tablets to do their consults. But obviously with COVID-19, that's probably a less likely scenario. But yes, I think with the costs coming down.
About our patients who use the library computers, which of course are not not open at the moment.
I know.
How do GPs go about accessing this program from via their primary health network or via WAFA?
By WAFA, yes. So we'll be working with WAFA to make sure we can make some arrangements to get access to GPs as soon as possible. So what we've been doing with other PHNs is basically setting up an organisation within the platform, and then underneath that organisation are all the clinics that are in that region, and we can. But yes, in terms of logistics, it's really just making how are they going to make GPs aware of this, and how are we going to get the information about the practice, about the person who will manage this within the practice, because what we need is someone within each practice who will be able to add the GPs into it and be that sort of point of contact, to be the sort of super user within that clinic.
Sorry, I'm just mindful of time.
Yes,
if they're wanting to sign up or ask questions about this, do they contact WAFA or do they contact you direct? We can send the details out to the participants.
Yes, so we can. People can contact us directly. However, I think in terms of making it a streamlined process, we would need to quickly work with WAFA to set up some logistics around. Perhaps they can contact WAFA when WAFA gather a group or a list of GP practices with key contacts, and then pass that to us, and then we can get them set up. So I think that sort of arrangement has been working well with other PHNs. So yes, so I'll get in touch with WAFA and make sure that we have a process that can work well between us and the practice.
Sorry, because we're rural. If it drops right out, what happens then? Is it just going to drop right out? Do we then have to just phone the patient?
So yes, so if there's a complete drop in internet, obviously you'd have the backup would be the phone. However, just to note, the system has been designed so if there's a quick, you know, a 30-second dropout, it will actually come back into the call. And I didn't show you an actual call in progress, but it essentially looks like any call, like a Skype call or a FaceTime call, but it will come straight back. And patient won't have to come back in through the link again. It will just reconnect. So it's been designed to allow for short dropouts and sort of ups and downs in bandwidth. And we do have a setting that allows for very low bandwidth to make sure that the call won't drop out, and you will have audio at a minimum. So yes, so we've designed it for those scenarios. Just need to make sure you've set it up to cope in that situation.
Well, audio is audio. Thanks so much, Jo. I'm sure that
Pleasure.
we're going to generate just as many questions as we're answering, and we hope that it's been of use to our participants, and that we'll be able to send you out some more useful information, which hopefully won't be quite so obsolete by Monday. Thanks very much for joining us, everybody.
Thank you all. Have a good night.
Thank you.
Stay safe.
Good night.